Hello, everyone. Hope you're doing well. Welcome back to Abnormal Psych 260, and now we're moving it online. So I'm going to continue from where I left off last week, which is talking about agoraphobia. Agoraphobia is a fear of being in public places or situations where escape is difficult or help unavailable. So this typically develops in the 20s and 30s, and it involves basically having a panic attack somewhere, and then you learn to avoid every place that you have a panic attack at to the point where you're not having, you're avoiding everywhere because you're having a panic attack at school, you're having a panic attack at work, you're having a panic attack, out shopping, on the streets, wherever. And every time you have a panic attack, you learn to avoid it because you don't want to have a panic attack. It scares you to death. So eventually, these people become so insulated from everything that they retreat inwards and they end up staying in their house, and they're no longer able to function within our society. So it's kind of similar to like what we're doing right now. We're all staying indoors, and this is the world of the agoraphobic. Staying in, don't go out, and don't socialize because they're afraid of having a panic attack. We're afraid of going out because we might get sick. So this develops early in life, and it can be lifelong, although it can be treated through exposure therapy and different types of medications. So some of the explanations for agoraphobia involve, uh, the fear of panic attacks, conditioned phobias through classical conditioning. As I mentioned previously, phobias develop very easily, especially to things that may be dangerous. They develop like in one trial. So it only takes like one panic attack for you to avoid a particular event or situation. And agoraphobia is often comorbid with a diagnosis known as panic disorder. And panic disorder is when someone's afraid of having a panic attack, and they're like obsessing over panic attacks, and they're afraid of future panic attacks, and that often goes hand in hand with agoraphobia. Very rarely do you see agoraphobia without the presence of panic attacks or even panic disorder, which is like a more extreme version of panic attacks. So you have multiple panic attacks, and now you're afraid of having a future panic attack. Treatments for agoraphobia include exposure therapy, which we've talked about before. So like go out a little bit at a time. Support groups. So support groups include like online discussions, which would be really popular in today's fear-based environment that we're living in, online support groups, and home-based self-help. So people coming to the home to help this person. It could be a therapist that comes to the patient's home to work with them because they're afraid to go to the therapist's office. And so agoraphobia, I mean, not to make light of it because it's a very serious illness, their behavior is very similar to what we're doing right now. People are afraid to go out. You're stuck at home or stuck in your apartment. You can't leave the house. And this kind of is what an agoraphobic feels like, on a regular basis, except that everybody else is going out and they're stuck at home. So that makes it even worse. But, imagine, just think about all the frustration you have being stuck inside and the fear of going out. And that's what agoraphobic feels like every day. Plus the comparison of, look, my friends are going out. Why can't I go out? The whole world is going out. Why can't I go out? And that's what agoraphobic feels like on a regular basis. They can like go very short distance from their home, just as we can go maybe outside somewhere where there's not a lot of people right now, but they can't really go out more, further away and for a longer period of time. And it's quite frustrating, as we're all seeing right now. Now, moving on to social anxiety disorder. Social anxiety disorder is another complex phobia in which people have persistent fears of one or more social situations. Now, this is not just I'm afraid to like talk in front of an audience, or I'm afraid to give a speech, or this is something that's interfering in your daily life. That's lasting at least 6 months or more, and you're afraid of being negatively evaluated by other people. So the easiest way to avoid being negatively evaluated and having anxiety responses is to avoid. And for social phobia, that avoidance could be talking in front of others, performing. There's musicians that, they couldn't perform live. They could perform in the studio, but they couldn't perform live because of social phobia. Eating in front of other people. There are plenty of people that will not go to a restaurant because they're afraid that people are watching them when they're eating, or even writing in public, which is really bizarre. But if they feel like someone's watching them, they can't even sign their name. So this can be quite debilitating as well. I mean, it's not to the extent maybe of an agoraphobia, but it's really limiting people from interacting with others, and really ruining their ability to form bonds and relationships with their peers. Could even hamper someone's ability to hold a job. This can be broad-based, so they have this general fear of functioning poorly, or it could be more specific. So some people may just have like intense fear of public speaking to the point where, they can't do a job that they're asked to do. Or it could be like an intense fear of using public restrooms to the point where they don't want to go out because they can't use public restrooms. And in this social anxiety disorder, people feel that they just can't do these things, even though there is some evidence that they could. They don't want to take the chance. They've kind of learned that avoidance is probably the easiest way to go, and it's not worth it. So what causes social anxiety? Cognitive theorists talk about people with this disorder having expectations that work against them. So they hold unrealistically high social standards. So they view themselves as, I'm not good enough, and therefore I won't try. Or these people will think negatively about me or shun me, therefore I won't do it. These people also view themselves as unattractive, as socially unskilled and inadequate, as a danger of behaving incompetently. They think that there's going to be negative consequences for this poor behavior, for this socially restrictive behavior, and they feel that they have no control over their emotions. So these are 6 good reasons to not even bother. Why bother going for the job interview? Because I know I don't perform well in front of other people, and I'm going to make a fool out of myself, and I probably won't get the job anyway. So I'm not going to even bother. That sounds like a pretty good reasoning from someone that has social anxiety. Or why bother trying to go out on a date? Because I'm very unattractive. No one would want to be with me. No one, people are going to think I'm strange. I can't do the things that other people do. So therefore, I'm not going to bother. And that gets reinforced because what happens is you then avoid the anxiety-provoking social situation, and you stay home or whatever, you do nothing, and you feel better. Temporarily, you feel better about yourself because we don't want to be in anxiety-provoking situations. We want some control over things, over our life, and this is a good way of controlling it. Now, in the long run, that's going to make somebody miserable, depressed. It's going to compound other problems they have. It's going to increase their anxiety as a whole. But in the short term, it's easier to say no and to avoid. Treatments for social anxiety. Social anxiety used to also be known as social phobia, so you see that kind of interchanged. The reason why we don't like the term social phobia as much is because phobia generally depicts one particular, feared object or situation, and for the social anxiety case, it's multiple. It's kind of in the same boat as agoraphobia. It's a very complex fear system that's been set up from a very young age, and it's really difficult to change. So, as I mentioned with all other treatments, agoraphobia and simple phobia, exposure therapy. So put them in the anxiety-provoking situation and see what happens. Well, you could do that. But you want to do it in very small steps. So you want the graduated exposure therapy, your systematic desensitization. You do not want to do flooding with these people because you're going to terrify them to the point that they're going to be not want to come back for therapy at all. Flooding is too strong for something like this. I would advise against flooding in almost every situation. You also have a lack of social skills with people that suffer from social anxiety. And the reason they have a lack of social skills is because they've avoided. So they haven't had the normal interactions with other people, their peers. They haven't had the normal dating skills of other people. They've kind of been, sheltered to themselves, and as a result, they're a little behind. So they can be quite a lot older before they're able to tackle some, basic life milestones like dating. They're just so used to avoiding it that it can go on for many, many years. So they're going to need some social skills training. How do I behave in the presence of other people? How do I start a conversation? How do I build self-confidence to succeed in a social situation? And also assertiveness training. So how do I go out and make what I want happen? Not aggressiveness, but assertiveness. Being able to function, being able to demand respect from other people. Due to the lack of social interactions, these clients tend to be behind where they would normally be as far as it relates to their chronological age. They've been avoiding for years, decades of their life. Now I return back to panic disorder, which also is comorbid with agoraphobia, as I mentioned before. Panic disorder is just a extreme fear of having panic attacks. So panic attacks are shortened bursts of adrenaline that will occur, peak, and then pass. It could take 10 minutes, it could take a half hour, it could take the greater part of an hour. But these panic attacks will always subside. However, if you've had a panic attack, and I know I've had them, you don't think that at the time, especially your first panic attack. You're just like, where did this come from? Help me, I'm dying. Sort of that's that feeling, like, why is my heart pounding? Why is my heart pounding so hardly to the point where I feel like I'm having a heart attack or something is seriously wrong? And let me call 911 or let me go to the hospital because I don't know what's going on. And that could be so overwhelmingly traumatic to someone that they just that's all they think about and how to avoid this. How do I prevent myself from feeling this way again? And it's not just, heart rate increasing or feeling like you can't breathe. It could also be dissociative experiences with panic attacks like derealization. So you could be sitting in a situation where you feel that the world isn't real. Like, am I really here? Like, what is this place? You feel almost like you don't belong there. You don't understand it. So you're living in a moment where you don't understand it, and it's quite scary because, as a human being, you want to be able to have some semblance of control and some understanding of your current situation. And if everything feels kind of foreign to you, that can easily increase the amount of panic you're having. So that can occur with panic attacks. Or you can have this other dissociative experience where you feel like you're outside your own body. Some people describe it as like they're like floating and they can see themselves from like above temporarily. And that could be extremely disconcerting as well and cause anxiety. So there's a lot of scary symptoms of panic attack that can lead to panic disorder, especially if you keep being afraid and trying to avoid. And then once you have panic attack and panic disorder, there's a very good chance you could end up with agoraphobia. So now you're afraid of panic attacks, you're deathly afraid of having one, and you avoid every place you think you can have one to the point where you're stuck. And now you're, in your house or your apartment or whatever room you're renting, and you're not coming out, similar to what's happening right now in our lives. We're not coming out for the most part. But in this case, this is pathological, where they're not leaving. But it's that kind of feeling. It can be very depressing for someone to be in a situation where they feel that they can't leave and they have no freedom. After a week of being kind of inside right now since last week. It's kind of like drives you crazy, right? And you just want to get out. I mean, human beings are not meant to live in isolation. But that's what's happening to the agoraphobic or the person with severe panic disorder that just is deathly afraid. So, panic disorder and agoraphobia definitely highly comorbid. So, more than one quarter of people will have one or more panic attacks at some point in their lives, and some have it repeatedly. If you have it repeatedly, you're more likely to develop panic disorder, where you're thinking about panic attacks and you can't keep your mind off of a future panic attack. Excuse me. And as I mentioned, panic disorder is frequently accompanied by agoraphobia, and this can lead to all kinds of problems. People are afraid to leave their house, travel, etc. So, what biological factors contribute to panic disorder? Well, we think it has to do with some kind of dysregulation of norepinephrine. Norepinephrine is a excitatory neurotransmitter that's been linked to depression and anxiety. And there's something irregular about norepinephrine in terms of panic attacks. So the part of the brain that's regulating norepinephrine is the locus coeruleus. And there's some change going on there where people are either producing more norepinephrine or their body is more sensitive to norepinephrine. We don't know exactly what's going on, but it's a false alarm. A panic attack is a false alarm, so there's some abnormality going there that's not inherently dangerous. But of course, you interpret that sudden surge of adrenaline out of nowhere. That's what a panic attack is, the sudden surge of adrenaline out of nowhere. We interpret that as dangerous, as something to avoid. Recent researchers looked at the role of the amygdala as being maybe involved in norepinephrine dysregulation and panic disorder. Um, we don't know exactly what's causing it. It's a false alarm, and some people are more prone to develop it than others. Could be genetics. The treatment is antidepressants, and in some cases, anxiolytics, which are anti-anxiety drugs. The problem with the anxiolytics or the anti-anxiety drugs is that they're very easy to develop tolerance, withdrawal from them, and some people will claim that you become addicted to it. But you take high and high dosages of the drug, and that's hard to get off of. So antidepressants would probably be the main road you would go here. And the non-stimulating antidepressants, the SSRI drugs, like the Paxil or the Lexapro, which is more sedating than, say, Prozac. Prozac's more stimulating. They've given Effexor, which is a norepinephrine and serotonin reuptake inhibitor, to people with panic disorder. Some people have good results with that, some people don't, because those drugs increase norepinephrine. And so I would probably stay away from that, but there's been mixed evidence with regard to using those SNRI drugs to treat panic disorder. The main treatment is SSRI drugs and the more sedating SSRI drugs, Paxil, Lexapro. Some would say Zoloft, but Zoloft's kind of a mixed bag. Also, Tofranil, the tricyclic. Don't want to forget about that. Tricyclic antidepressant, so it's an old school antidepressant developed in the late 1950s, 1960s. The problem with the tricyclic antidepressants that were the first generation antidepressants is the side effects associated with these tricyclic drugs. These tricyclic drugs they stimulate the histamine receptors, which make you very tired and lethargic. So giving a tricyclic antidepressant like Tofranil as a treatment can make you very tired. It can also make you sleep a lot. So it's best taken at night. It can also lead to weight gain, more so than the SSRI drugs. And probably the most troublesome side effect of the old tricyclic drugs are tricyclic antidepressants, that is, are that they can, in some people, create abnormal heart rhythms. More specifically, prolonged QT syndrome, which is the interval between the heart contracting and then refilling with blood. And if that interval, the QT interval, gets extended, uh, eventually you can end up with a fatal arrhythmia. You can end up going into ventricular fibrillation, which can deteriorate really quickly into asystole, which is no heartbeat, which is death. So there have been cases where people have developed this long QT syndrome from using tricyclics. It's rare, but it has happened. So anyone with a history or family history of heart abnormalities should be careful with that. SSRI drugs as a whole are safer and have less side effects. I mean, they have side effects, but they have less side effects. So people need to take one of these drugs, start with the SSRI drugs. If they don't work, you can then try the tricyclics. They tend to avoid the anxiolytics, or what I call, or what everybody calls, the benzodiazepines. Uh, they are Xanax, Ativan, Clonopin. You can throw a Valium in there, but Valium is typically not given at all. Um, for these kind of disorders. So Xanax, Ativan, Clonopin are typically given, and Clonopin is probably the most commonly given benzodiazepine because it has a very long half-life. And since it has a very long half-life, there's less likely the ability to get tolerance and withdrawal from it. Whereas Ativan has a very short half-life, and there's more of ability if you take Ativan consistently to get develop tolerance and withdrawal when you stop taking the drug. And Xanax as a whole, also the same thing, easily build tolerance and withdrawal. So the safer of these benzodiazepines is Klonopin. And so Klonopin is the general treatment for this disorder, panic attacks. Now, there is some evidence to suggest that if you take benzodiazepines to prevent panic attacks, that you will offset the role of systematic desensitization. So if you want to utilize systematic desensitization or exposure therapy, you don't want to be taking benzodiazepines because it kind of offsets the systematic desensitization from working. It's best to take the antidepressants. So those are generally the recommendations. Start with the antidepressants. Start with the SSRI drug, whether it's Paxil, Zoloft, Lexapro, something more sedating. And if that doesn't work, you can try the SNRI drugs, the serotonin and norepinephrine reuptake inhibitor drugs. That would be like Cymbalta or Effexor, although those tend to be very stimulating, so you don't want to really, you got to be careful with those with anxiety. And you can move to the tricyclics if you have to, tofranol being the most commonly chosen one. Drugs work for these disorders. I mean, drugs will work for panic disorder or panic attacks. They'll suppress it. In some cases, it will eliminate it. How it works, whether it's the norepinephrine dysfunction, we're not 100% certain. We think it could be that. But like a lot of things in the brain is so complex, we don't know for certain. But in 80% of patients, this is pretty useful treatment to utilize. And to avoid the anxiolytics or the benzodiazepines, because they give way to tolerance and withdrawal. Tolerance meaning you have to take more and more of the drug to get the same effect, and the withdrawal is the nasty physiological and psychological reaction to stop when you stop taking a high dosage of a drug. And those benzos or benzodiazepines have a lot of painful withdrawal symptoms. And in some cases can be extremely dangerous. So you wouldn't want to withdraw from benzodiazepines really quickly because you could end up having a seizure. So that has to be done very gradually, like over a period of months, to withdraw from higher doses of this. So if you can avoid these with panic disorder, you want to try to, or consistent panic attacks, you want to try to do that. The cognitive theorists, on the other hand, recognize that biological factors are only a part of panic attacks. So full-blown panic reactions are experienced more likely by people who misinterpret bodily events. So there are people out there that will scan their body. This could be part of hypochondriasis, right? Or what is known as now illness anxiety disorder. They scan their body for any kind of disruption. Like if their heart skips a beat, they notice it right away. My heart skipped a beat, something is wrong. Something's wrong. Am I having a heart attack? Is something wrong with me? Am I going to die? There are plenty of these people out there. And if you're scanning your body for any kind of problem or deviance from what you expect, you're going to find a lot of things wrong with you. Your heart does not beat like a drum. Beat, beat, beat. It's not like a metronome beating. It varies. Sometimes your heart speeds up. Sometimes it slows down. Sometimes you have what are called premature atrial contractions, PACs, or you have premature ventricular contractions, or PVCs, that occur. They're like false heartbeats. And that can cause you to have like the sort of bump, like the little double thump, or the little bit of irregularity that you may notice, or you may feel like a little flutter in your chest. That is almost always perfectly normal. If you have no underlying heart disease, and you have no abnormality within the structure of your heart, these are perfectly normal. People get them. Some people suggest, aerobic exercise to reduce or suppress these premature contractions, whether they're PACs. And PACs, premature atrial contractions, these are not dangerous at all. PVCs are generally okay, generally not dangerous. I mean, you should have them checked out, but a lot of times they're not a means. Premature ventricular contractions that's not a means for like going to the doctor and like panicking. This stuff is pretty normal, but for someone that's like scanning their body for signs of abnormality, you're going to find it. And then cognitively, you're going to interpret it and say, oh my God, my heart just skipped a beat, or my heart beat twice or three times like this. Something's wrong. I'm going to die, or something bad's going to happen to me, or I'm having a heart attack. And you can see the cognitive thoughts, right? They're not logical. This is not logical. But to an everyday person that doesn't know much about how the heart works, they're going to just panic. Just as you see many people panicking today in general society, doing all kinds of crazy things that are completely illogical. This is what happens when people scan their bodies for signs of their bodies not functioning. And they get scared and they think there's something wrong. And so what they do, they pay more attention to what's happening in their body, and they heighten it. They amplify these normal physiological variations. I mean, these are normal. If your heart was beating like a metronome and never changed at all, that's more of a problem structurally than it is if your heart varies a little bit, right? I mean, if your heart never wavers and it's beat, 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 there's a higher likelihood there's something's wrong with that than if your heart slows down sometimes, speeds up. Skipping a beat, this is not dangerous. Generally, they go away. Maybe it's a magnesium problem, could be. Maybe it's a exercise problem. Maybe you just need to, start doing more aerobic exercise and to suppress these false beats. But this is one example of how people do this. Or if someone has a headache, they think there's something's wrong with their brain. Could it be a brain tumor? Chances are it's not. Brain tumor is like the last thing on the list that it could be. It could be a tension headache. If you have nausea and visual disturbance, it could be a migraine. I mean, it could be, post-workout headache, post-exertional headache. There's a lot of different things it could be rather than being a tumor or cancer or something else that you hear from people all the time. Maybe it's cancer. I need an MRI. Really? Okay. There's a very small chance. Obviously, that chance exists. I mean, there's always a potential for it to be cancer or something inherently dangerous like that. But out of the possibilities of it, what it could be, cancer is last on the list. Even if you're older, cancer is last on the list. But people don't see the world this way. They're just panicking, and that sets off a chain of events that lead to a panic attack. And so those illogical thought patterns need to be challenged and changed through cognitive therapy. And as I was discussing, scanning your body. This is bad. You're going to find something wrong with you, especially if you have high degrees of what's called anxiety sensitivity. So these people focus on their body sensations most of the time. So if you're high on anxiety sensitivity, you're going to scan your body, and interpret any deviations as harmful. And this is what's going to lead to increases in panic attacks, eventually panic disorder, and then eventually agoraphobia. And that's where you don't want to be, because once you're into agoraphobia, it's a long road back. I mean, it's possible, of course, but it's quite a, you know, a big problem that you have to overcome. It's not something that you can just get over really quickly like you can with a simple phobia. Agoraphobia is something that's going to take months, if not years, of your life to really battle through and get back to some semblance of normality. So in cognitive therapy, they also use biological challenge. Now, I don't know how I feel about this, but what they'll do is they'll engage you in a physiological routine. So jump up and down to the point where your heart's beating faster. And now, after you keep jumping up and down, your heart's beating really quickly. Now, stand there and feel your heart beating fast, and realize that, nothing's going to happen to you, that you're going to be okay. Or run up a flight of stairs, or 2 flights, or 3 flights, right? You're out of breath, you can't breathe, your heart's pounding, and just feel it and get used to it. And now you'll see that this kind of behavior will return to normal, and it's not inherently dangerous. You just have to be careful with these things, in that people don't overdo it. You don't want people exercising in a way where they're really pushing the limits to the point where, they could have a problem. So keep this in moderation. Don't. Some people, when you tell them, okay, get your heart beating, they're gonna run up the flight of steps, but they're gonna keep going to the point where, they may not be in good enough shape to be able to take that, and then they're gonna feel really awful afterwards. So you want to keep it sort of contained. Listen, you feel that heart beating at like 150, 160 beats a minute. Let's not get that up like over 200, because that's a situation that we really don't want to be in. You don't want anyone being in a situation where they're working out so hard that their heart rate's over 200, because that's, in a prolonged period of time, that's not something that's good for you. So within moderation, it's okay. Now we're shifting to one of the most really difficult and entirely disabling disorders that has always been part of the anxiety disorder spectrum, but now in the DSM-5 has been moved to its own category, and that's obsessive compulsive disorder. So in obsessive compulsive disorder, you have 2 components. You have obsessions, which are the reoccurring thoughts and impulses, things that you can't get out of your head. And you have the compulsions, which are the behaviors that you utilize to reduce the obsessions. So think of the obsessions as anxiety. So, I have to check. So I leave my apartment, and now I have to check to make sure my door is locked. Well, before I leave, I may have to check every single possibility, right? Is this door locked? Is this secured? Is the stove off? Are the electrical appliances that are dangerous, are they unplugged? And I'm checking, and I'm checking, and I'm checking. And I'll check it once, and then I'll check it again, and then I'll check it again. And I keep checking to the point that it takes me a half hour to leave my apartment or my house. That's an obsession. You're worried that something's going to happen. There's going to be an accident. You left the stove on, or you left something plugged in. You left your space heater plugged in, and it's dangerous, can catch fire. Or you left the door unlocked, and someone's going to break in. So you're going to check constantly. And the checking itself reduces the anxiety. So the obsession is the anxiety about something bad happening when you leave, right? A fire or a break-in or something else. Those are the obsessions that you can't stop. They're just overwhelming you when you try to offset them with the compulsions. Compulsions being check everything multiple times, so I reduce that obsessional anxiety. A more current problem that could lead to OCD, I can see very easily, is the whole washing your hands thing. It's always good to wash your hands, but it's only good to wash your hands once at a time. If you spend your 20 seconds washing your hands, or what they say the alphabet or sing happy birthday to yourself, that's great. Now you're sanitary, all good. But I could see the current situation leading to OCD with compulsive hand washing, even more than it is now. You're washing your hands and you feel anxiety about your hands having germs or viruses on them, so now you're washing them again and again and again because of all this obsessional anxiety about having germs, viruses, etc., that are dangerous. And you're hearing it all the time: wash your hands, wash your hands, wash your hands. Well, some people can wash their hands thoroughly once and be done with it. Combine this advice of washing your hands with the underlying anxiety regarding the situation at hand in the world, and you have some people that are more prone to OCD, and they're going to become compulsive hand washers. They're going to keep washing their hands 5, 6, 7, 8, 9, 10 times in a row to the point where their hands are dry, peeling, bleeding, cracking, bleeding, etc. That is a pathway to OCD. Obsessional anxiety, and then you perform the behavior, which is the compulsion, to offset the obsessional anxiety. Now, if this gets out of hand, or it's interfering in your daily life, so let's say you can't go to work. Well, we can't all go to work anyway right now, but let's say that the situation resolves and we have to go to work and we have to do things, take care of our families, and etc. Take care of our business. If it interferes in you doing these things, then you have possibly obsessive compulsive disorder. So it interferes with daily function, it takes up too much time, and it causes you a great amount of distress. So if you're washing your hands and you can't stop, and you got to wash your hands for a half hour because you're afraid of germs and viruses, and if you don't wash your hands, the anxiety is 10 times fold that you have to go back to it. That is the development of obsessive compulsive disorder. So it's kind of too much of a good thing. And there are many people throughout the world that have severe forms of OCD where they can't function. So there were a couple of teenagers that I had talked to that had extreme OCD to the point where they were going through rituals in the morning to get ready for school. For example, one girl was washing her hair constantly. So she would spend over an hour in the shower just washing her hair, re-washing her hair, washing her hair. She couldn't leave. She couldn't go to work or to school before she did this. She had to wash her hair over and over again for over an hour. And that was interfering. She was late for school and she wasn't functioning well because she kept washing her hair. And the same thing with washing your hands. If it prevents you from living your life or taking care of what you have to take care of, your job, your loved ones, etc., it's become a disorder. These are very difficult disorders to treat. I mean, there are treatments, but they're not like taking a pill is not going to work too well for OCD. It may help a little bit, but OCD is a lot more complex than just taking a pill. So OCD has always been classified under the anxiety disorder, although with the DSM-5 it's been moved into a separate category. But I still consider it an anxiety disorder because the obsessions are anxiety-based. It's not just these obsessions where someone's okay with not doing it. That it's extreme anxiety if they do not perform the compulsive behavior. So if someone with OCD is prevented from engaging in the behavior to offset the obsessional anxiety, they're going to suffer. They're going to feel building anxiety to the point where it's very uncomfortable. They cannot deal with it. And it has a prevalence rate of 1 to 2%, and lifetime over 3%, which is a huge amount of the population. It's equally common in men and women and among different racial and ethnic groups. And more than 40% of those with OCD seek treatment, which tells you that it's a very disabling condition because people generally don't seek treatment, psychological treatment, as a whole, people with disorders in this country. And 40% of OCD sufferers do seek treatment, which means that the problem is severe enough that they will go out of their way to get treatment. And there are people that are treated, through the phone, through Skype, through FaceTime, from all over the world. You can, distance treat people, or you can treat them locally as well. But there's a large segment of the population that needs help with this disorder. So as I was mentioning before, obsessions are thoughts that feel intrusive and foreign. They trigger anxiety. That means if you try to ignore them, the anxiety will just keep building. And they take various forms: wishes, impulses, images, ideas, doubts. So something's going to happen, and they have to take care of it, right? Someone's going to get hurt, or someone's going to die if I don't engage in this behavior. So it's very serious condition. It leads to extreme anxiety. And the common themes include dirt contamination, aggression, orderliness, religion, even sexuality. So, I've seen people perform religious compulsions where they have to touch a statue a certain number of times in a certain way, at a place of worship like a church. They'll have to touch a statue, and they'll engage in a ritual that their OCD is very severe. And they'll do it for hours at a time. I've seen it happen for hours at a time. Hours at a time. Now, I wasn't involved in the case, but I witnessed the case, and it was fairly disturbing. And I was like, why is this person doing this? And I was told that this person has extreme OCD, and this is the ritual they do every day. They go up to a statue in a church, and they touch it in various ways, and it's a whole routine. And to me, it's disturbing, but it's a clinical problem. The person has a sickness, and they need to work on it. So we just hear about dirt and contamination, especially now. You're going to see this. I think this is going to skyrocket, this contamination, OCD. The society is just set up for this at the current moment. But you can see it with orderliness. So I know of another case of someone that has to have a certain number of pencils on their desk at the same time. And if you don't have that, they get upset, right? Their anxiety goes up. So like multiples of 2 or multiples of 3. It doesn't make any sense. It doesn't have to make sense. That's why it's an obsession, right? If it made sense, it wouldn't be an obsession. People would say, this is not helping me, so why am I doing it? But the person suffering from OCD is unable to stop it without treatment. Common compulsions include checking, cleaning, touching, counting. These are the behaviors to offset the obsessional anxiety. Now, in terms of OCD, the explanation from a psychodynamic perspective is that children come to fear their id impulses and use their ego defense mechanisms to lessen their anxiety. So in this case, the id impulses lead to the obsessional thoughts, and then the ego defense mechanisms try to counter those thoughts, which leads to the compulsive actions. So the id is saying, I want to do this, I want this right now, I want this, we have to do it. That's the id. The id is like that little baby that just keeps crying until you give him or her what they want, or the child that goes to the store and whines and whines and whines, like, I want that toy now, give it to me. There's no delayed gratification. That's your id. So the id is the obsessional thought, and the ego is trying to counteract the id by performing the compulsive action. That's the OCD from the psychodynamic or psychoanalytic perspective. Now there's this battle going on between the id and the ego, and the ego has defense mechanisms including isolation, so they can ignore the disturbing thoughts, or they can perform undoing. They can perform acts to cancel out those thoughts. So the undoing is the compulsion, and that's a very easy way to cancel out the negative thoughts, because it's really hard to isolate them because they're constantly there. Or from the psychoanalytic point of view, you can engage in what's called reaction formation. This is when you take on a lifestyle that's the opposite of these unacceptable impulses. So let's say you had these, horrible obsessional thoughts about stealing. Well, one way to counteract that without doing an act, performing an action, a compulsion to offset it constantly, would be to take on a role in society that would be the opposite of that impulse. So you can see that person say, okay, this is totally unacceptable. I have these impulses that I want to steal from every store I go into, the sort of kleptomania. And in the case of kleptomaniacs, though, they do actually steal. There's no OCD-like conundrum here. But let's say you have that urge to steal, that obsessional when they steal, but I know stealing is bad. You can transform your behavior and you can start doing community service for people, or helping people, counseling people. So you're taking on a lifestyle that's opposite of the obsessional impulse that you're having, and that would be reaction formation. Reaction formation is basically engaging in the opposite behavior of what you're really feeling about, what you're feeling at the moment. Freud believed that OCD was related to the anal stage, so he thought this was fixation at the anal stage of development, where a child wants to exercise control over bowel and bladder elimination. So this is a very difficult period of time for the child, and the conflict between the id and the ego. So in case of bowel and bladder elimination, the id wants to, I want to go pee. I want to pee anywhere. I don't want to have to wait. I don't want to have to hold it till I get to a toilet. I want to pee. I want to pee now. And the ego is like, well, wait a minute. I'm working by the reality principle, and, this is not acceptable in society just to pee wherever you want. You have to engage in the socially appropriate action, which is go to the bathroom, use the toilet. So there's a conflict right there between the id and the ego, starting at 2 or 3 years of age. And Freud believed that this conflict was not solved or not dealt with properly, and that makes these people later in life more prone to OCD and to be highly controlling. However, just like everything Freud says, not all psychodynamic theorists agree. Different theorists have a little bit of different explanations rather than the id and the ego battling it out. Many psychodynamic theorists are uncomfortable with just purely talking about id and ego and superego. From a behavioral perspective, when we're in a fearful situation, you can perform an act like washing your hands. I think we're all familiar with that now. You're in a fearful situation, what do? You wash your hands. That's a good thing. Once. If you go out, you wash your hands when you come in. You go to the store, you wash your hands, especially in today's day and age. However, when the threat lifts, they then associate the improvement with the random act. So, washing hands is good because it prevents the spread of disease, germs, bacteria, viruses, etc. But once the crisis is over, now you've classic conditioned washing hands with safety or a pleasant state, a state of no harm. So you've conditioned washing hands with no harm, being well. And so now washing hands becomes reinforced. So you start washing hands more often. Things are still good. That strengthens the behavior even more. Now, what will happen after this whole crisis, this whole virus crisis? People have been taught to wash their hands so much. When it's all over, will people develop a compulsion of hand washing at a greater rate than they would under normal situations? And the answer is probably. We won't know until years from now, but there could be a whole development of obsessive compulsive disorder based on hygienic hand cleaning. That people just don't get the message and they start washing their hands under every situation. I mean, that's a good thing to wash your hands, but it's not a good thing to wash your hands to the point where they're bleeding. The obsessional washing of hands is not a good thing. So will there be more of these cases in the next 5 or 10 years? And I would say probably, because this has been reinforced that washing hands is good. Washing hands prevents illness. And, I think people will continue to do this, and some will do it compulsively. And after repeated associations, behaviorist theorists think that compulsions actually change the situation. So, this is a case where people engage in superstitious behavior. So if you have this superstition and you perform this ritual and then you have success, let's say you're going for a job interview and you have your lucky, item. Used to be lucky rabbit's tail, whatever you consider a lucky item now. And, 4-leaf clover, etc. And every time you have this in your possession, something good is going to happen. Well, in some cases, this can go too far. Where if the person forgets their lucky item, the whole world will crash. The whole world will come down. They cannot function. And this is when the repeated association between this item and success happens. I took my lucky rabbit's tail and I got the job. So now I have to go everywhere with my lucky rabbit's tail. It means a lot to me because this is what's causing me to get the job or to have success in my life or to be healthy. And that gets reinforced, and then someone can't give that up. It becomes, pathologically a part of them. And that's through behaviorism. I mean, there's no causal influence of a lucky rabbit's tail on getting a job. But just pairing those two things together lets someone see the causal influence there that doesn't really exist. And this can be a way of reducing or avoiding anxiety in the future because this particular act or this particular ritual has been associated or conditioned to a positive outcome. And of course, if we're talking about the behavioral perspective, we have to talk about therapy. And as we mentioned numerous times throughout this chapter, exposure, actually we didn't talk about exposure and response prevention. We talked about exposure therapy, but let's more specifically talk about exposure and response prevention here. So if you have OCD, what you want to do is expose your client to the anxiety-producing situation. So let's say it's compulsive hand washing. So what you want to do is put dirt on your client's hands and prevent them from washing their hands for a period of time. Now, obviously, during this day and age, with the whole virus situation that you can't get away from, this wouldn't happen, right? I mean, no chances would be taken under these circumstances. But let's say that the world, calms down and eventually this thing peters out, and we can actually, put our hands somewhere. We can actually go out and touch something and not be worried about dying or getting someone else horribly sick and dying or killing somebody else. When we get back to that point, which is going to happen eventually, in either a good situation or a disaster situation, eventually the virus will be resolved through either suppression of the virus, which is what we're trying to do now, or herd immunity, which is what we don't want, where basically everybody gets sick and many people die and we develop resistance to the virus that way. That's like the disastrous situation. We don't want to go there because too many people will die in that route. I mean, actually, they estimate that probably 1 million people, 1 million U.S. citizens will die if we actually went the herd immunity route. So when they tell you to stay indoors and don't go out, they mean it for a reason. Because if everybody keeps going out, it's going to be herd immunity, and we're going to lose 1 million people. We don't want that. But the virus will end either way, suppression or herd immunity. So once that situation is done, we can then go back to treating these people that have the hand washing compulsion by putting dirt or having them touch a dirty surface and have the germs on their hands, which will immediately cause the obsessional anxiety to trigger. So I need to wash my hands. I need to wash my hands. Oh my God, I got dirt. I got germs. I got this. I got that. Right? Under normal circumstances, that's not healthy, unless you have, viral pandemic. But under normal circumstances, that's not healthy behavior. Prevent that person from washing their hands. So it's exposure. You've exposed their hands to dirt, germs, etc. And it's response prevention. So you're preventing them from actually washing. That's the compulsion. So you're dealing with the obsessional anxiety and also preventing the compulsive behavior. And if you do this and you extend the behavior out longer and longer, so you may start by saying, here, your hands are filthy, dirty, don't wash them for 30 seconds. That's going to be a lot of anxiety for someone that has compulsive hand washing. So they do 30 seconds. Let's do the same thing, increase it to a minute. Now increase it to a minute and a half. Now increase it to 2 minutes, etc. Until you keep extending it and the anxiety starts to slowly dissipate, right? That's the goal. Expose them, allow them to have the obsession, but prevent them from engaging in the compulsive behavior. And then lengthen it out slowly over time. And then you have exposure and response prevention. And this is a very effective method. I mean, this requires homework. I mean, it requires your client to actually take it seriously and keep working on it. But this works. Between 55 and 85% of clients are successful, show improvement with exposure response prevention. So this is different than just, exposure therapy, which is called systematic desensitization, or flooding, which is the extreme exposure therapy. This is exposure and prevention of the behavior, which is the compulsion. So in the case of the germs, it's it's prevent them from washing their hands. In case it's the checking, prevent them from checking. So if they have to check their house for a half hour before they leave, once they leave, they leave. Now they can't go back and check to see if the door is locked, to see if the stove is shut off. You prevent this. Slowly increase it over time because the anxiety will be tremendous at the beginning. And we need to slowly move this out to the point where the person's obsessions lose their power. However, given that OCD is a very difficult condition to treat, as many as 25% of clients with OCD will fail to improve at all. And there are some people that have what are called obsessions without compulsions, right? So the compulsions are mental, they're rituals. In their mind, they do the ritual. So they're not doing a behavior, an overt behavior, they're doing the ritual in their head. The ritual can be like anything, it could be counting, it could be imagining something happening, but the ritual is purely mental. If the ritual is purely mental, this technique is not going to work because this technique is developed for overt behavior, not for mental gymnastics or mental rituals. So there's a small people that have no overt compulsions, but they have the compulsions mentally. They're doing some kind of compulsive thinking to offset the obsession. And this obviously wouldn't work with those people. But this is a very effective technique to be used. And you can combine this with medication. Medication is kind of hit or miss. Medication doesn't work a lot of times. Now, in terms of the cognitive perspective, you need to tell people that they have illogical, repetitive, and unwanted thoughts, right? And that nothing terrible will happen to them if they do nothing, basically. So you're trying to point out the logic of their that their thought process is completely illogical, I should say, and that no matter what they're thinking about germs, just because you have germs on your hands and you're not immediately washing your hands doesn't mean you're going to get sick. And logically, that makes sense because you can have germs and not get sick, depending on your immune system, depending on the type of bacteria or virus. Now, obviously, this is all moot when we're talking about, an epidemic virus that spreads, rapidly and that is deadly in some cases. I mean, then you can't really, you can't convince somebody that nothing inherently bad is going to happen to them. But in general, if the person is not checking everything, there's not going to be disaster. Your house is not going to catch on fire. Your apartment's not going to catch on fire. Uh, if you don't have multiples of the number 3 on your desk while you're working, nothing horrible is going to happen to you, your family, or anybody else. These are completely illogical thoughts. So in most situations outside of national crises, uh, you can basically communicate that these thoughts, these obsessional thoughts, are totally illogical. Now, is this really effective? If the person has a severe case of OCD, it's very difficult to purely, change their cognitions because they're constant. And it's hard just to point out that this is illogical because they believe so much in it, and they've been believing in it for many years before they've gotten treatment. This is not something that just started. This is something they've probably been living with for years, if not decades of their life. So I would prefer the behavioral approach with exposure response prevention because it's much more reliable than cognitive restructuring. Now you could combine them and make it CBT, but the behavioral approach is what's really getting the most results here. The cognitive perspective also talks about neutralizing thoughts. So when you're feeling the anxiety, then change your anxiety thoughts and incorporate a neutralizing thought or action, which includes seeking reassurance, thinking good thoughts, and that will avoid the washing and the checking. So you're kind of trying to cancel out these negative outcomes, right? So you're substituting washing and checking with some other thought that will be reassuring in some way. Once again, has the potential to work, but I don't see the rates of success that you see with exposure response prevention. And generally, you don't see the behavioral isolated and the cognitive technique isolated. You see them together in CBT treatments. So you generally don't have them separated, but the behavioral aspect is going to be more successful than cognitive restructuring here. So why do people with intrusive thoughts, why do only some people develop OCD if multiple people have intrusive thoughts? Well, people develop OCD because people with OCD are more depressed than others. They may have exceptionally high standards in conduct and morality. They may believe thoughts are equal to actions and they're capable of bringing harm, so they kind of give more justification to their thoughts. Or they believe they should have perfect control over their thoughts and behaviors. So once again, you see more controlling. These people cognitively tend to be more controlling, and they also think that they have a disproportional influence on the world that they really don't. So they could be responsible about bringing harm. Their thoughts could bring harm to themselves or others, which is completely illogical. They also tend to have higher standards of conduct and morality. I would say that they tend to overestimate their cognitive influence on the world in general. From the biological perspective, there's some evidence that OCD patients have abnormal serotonin activity. So if you take serotonin-based antidepressants, that can reduce. Now you have to take a higher dosage of it. So you would need to treat with a higher dosage than you would for depression or anxiety. I would say double or triple the dose in some cases to really have any influence on OCD. OCD is a difficult disorder to treat with pharmaceuticals. There's some evidence from a brain imaging perspective that OCD is linked to orbital frontal cortex disruption and disruption with the caudate nucleus. So there's something going on with the frontal lobe that's not working properly, in other words. So these areas could be too active and letting through some troublesome thoughts and actions. So things you would normally suppress. So frontal lobe plays a role in suppressing thought and also suppressing behavior. So there's a lot of things that you think about doing, but you then, you see the big stop sign, right? So I'm driving down the road, I want to make a right-hand turn off the highway. Well, that would basically crash me into the side of the road. But I've actually had that thought several times where I just felt like, what if I made a right-hand turn here on this highway? It's completely illogical, but sometimes you have illogical thoughts in your head. And then the big red stop sign in my mind comes up and says, this is crazy. Well, why are you doing this? Why are you thinking of this? So definitely don't do it. You're going to kill yourself. But why are you thinking of this? And we have random thoughts, like you get angry on the road and you want to I tend to be an angry driver. So when I get angry on the road, I want to pull up to the guy or gal and basically start a fight with them. Like really start a fight with them. Like, how could you do this? Like, why were you driving like this? Why'd you cut me off? This is crazy. You're gonna get us killed. And sometimes you want to start a fight and you want to do something to that other person, because you're getting really angry. But you can't do it. This is not the way to behave. So once again, that stop sign in your brain comes up and says, don't do it. This is not going to lead to anything good. So just calm down, relax, move on before you escalate and you end up doing something you regret doing. Well, in the case of OCD patients, this orbital frontal cortex is not stopping, right? So they're having this obsessional thought, but instead of their frontal cortex saying, stop, nothing's going to come out of this, there's no point. Why are we thinking like this? The frontal lobe doesn't work like this. And so they engage in a behavior to try to offset that thought process because the frontal cortex is not stopping them from engaging in this behavior, this action, from linking this thought and this action together. How do you fix it? You don't. I mean, if it's actually a brain structure abnormality, like the orbitofrontal cortex is not as active for whatever reason, that's something you can't really change. I mean, there's no drug that would just specifically target the orbitofrontal cortex. So it's interesting for future research. Maybe there could be some kind of treatment targeting orbitofrontal cortex malfunction, but currently there's no real treatment for this. And lobotomy is not a treatment. You can't just remove the frontal lobe because that's going to make the problem 10 times worse. Now, the reason why we're thinking these things is because of the connection with serotonin. Serotonin plays a role in the operation of this orbital frontal cortex and the caudate nuclei. And abnormal serotonin activity could be contributing to some dysfunction here that could lead to OCD. Now, the caveat here is that serotonin has been linked with basically everything. It's linked with anxiety, it's linked with depression, it's linked with so many different things that, could it be another link with OCD? Yes. I mean, do we treat OCD with serotonin-based drugs? Yes. We treat them with SSRI drugs. SSRI drugs are used all the time. Prozac's one that's used a lot to treat OCD. Is it effective? I would say minimally to moderately effective. It's not very effective. So if it does play a role, it might be more complex than the role that our antidepressants are able to really target and to adjust. So as I mentioned, serotonin is used. Prozac, Luvox, which is another SSRI drug. SSRI drug is a selective serotonin reuptake inhibitor drug. But also the tricyclic anafranil is used in some cases to help treat OCD. And there's an improvement of 50 to 80%, but this is a very high dosage of these drugs, more than depression and anxiety. And 80% is really, I would say, a little high. I would say it's closer to 50%. And you may get some improvement, but it's still there. So if you want to treat with pharmaceuticals, if you want to do a pharmacologically based treatment, combine the SSRI with the exposure response prevention, and you get the best treatment combination. I think that's the way to go. The SSRI will somehow reduce the anxiety a little bit, and then the ERP, the exposure response prevention, will stabilize it. So where's the DSM find a diagnostic home? the DSM-5 has kind of put it together. Put it separately from the anxiety disorders, right? Although I do consider OCD to be anxiety-based because the obsessions are anxiety. DSM-5, in their righteousness and their whatever, has decided to put it in its own group along with hoarding disorder, trichotillomania, which is hair pulling, excoriation, which is skin picking, and body dysmorphic disorder. So they all go together in a group now called the obsessive compulsive related disorders. And they're all impulse control disorders, that's true, but they're also really tied into anxiety. It's hard to see how these 4 disorders, 5 including OCD, is not linked to anxiety at all. But they're all anxiety based. So whether you want to put them in their own group or not, I consider them tied to anxiety because they're all anxiety based. I think it's just more just a paperwork classification than a treatment classification. They're all anxiety disorders in reality. Hoarding, this one you're probably very familiar with given the current situation. Hoarding disorders is when people are unable to give up or throw out their possessions. And you're seeing a lot of hoarding behavior right now where people are unable to give up or throw out anything. They're collecting all kinds of things, whether it's meat, water, bread, I've been to supermarkets where I went to the supermarket last week and it was just the scariest thing I've ever seen. It looked like the apocalypse. The whole shelves were cleaned out. It was just absolutely crazy. And people were buying out, all things, especially toilet paper. And as crazy as that sounds, toilet paper is something that human beings have linked to crisis mode for a long time. It sort of gives them a feeling of control somehow. I don't necessarily understand why it does, but it does. That this is like a basic, need, a fundamental need, and if they have it, they feel that, they feel a little bit comfort in the fact that some of their fundamental needs are covered. I think it's very illogical, and I think it's counterproductive to be buying out all the toilet paper where you can't get toilet paper anywhere. But that's kind of what happens in a panic situation. People will hoard in a panic situation. Now, hoarding disorder goes a little bit further than just hoarding. Hoarding disorder is when someone will hoard everything and never throw anything out. So they feel that they have to hold on to old things that are falling apart, that are not needed, because they might need them in the future. They're unwilling to give them up to the point where their house or their apartment is so littered with debris that you can't even walk through it because there's stuff on the floor, there's everything everywhere. It's an impossible situation. And this causes impairment. They cannot give this stuff up, but you can't live your life in such a mess, basically. So it causes significant distress and impairment. Trichotillomania is hair pulling, so people will repeatedly pull at their hair to the point where their hair is falling out. They'll pull most of their hair out of their head because they feel this urgent need, which is anxiety-based, once again. You think of it as an obsession to pull the hair. Pulling the hair calms that obsessional anxiety impetus. So that's hair pulling. You can see how it's related to OCD. The anxiety, and then the hair pulling calms the anxiety. And then body dysmorphic disorder, where people are extremely anxious about their appearance and they have a distorted view of themselves. So they'll see themselves in the mirror in a distorted way as having a defect. So they'll have, a large nose they'll see their nose as gigantic and hideous, where in fact their nose is quite normal to the outside world, or their chin is gigantic, or something on their face, or something with regard to their body is disproportionate and abnormal, and they develop extreme anxiety towards this, and they'll constantly be checking themselves. And this can also lead to depression because they're not happy with the way they look. They think they're something seriously wrong with the way they look. leads to a lot of distress and impairment. And the obsessional part of this is checking. So they're checking, looking in the mirror, checking, looking online, checking, taking pictures, checking, and they're always comparing themselves to other people. So that's the obsessional part of the body dysmorphic disorder.